met in the United States. I was fortunate enough to have him come to my cancer center and more importantly over to my house and have dinner with my family. He's a great friend and a great professor. India is very, very fortunate to have somebody such as Manish here doing the orthopedic oncology for the country. We've been running this course for a long time. We started in 2000 in the Florida Keys, and we started the course. It was really just for residents to get them review for the boards. We started off with about 13 residents. It rapidly became very popular, not only for orthopedic residents, but for pathologists, radiologists. Now it's grown to the largest orthopedic oncology review course in the United States. We regularly have over 100 people a year coming to the course. We were then asked to go to Oxford and begin the course in Oxford, and it covers in Oxford most of Europe. We have about 80 delegates came to that this past year. So it's been very successful, and I'm certainly interested in working with Manish and hopefully develop a similar system here in India. It's a great review course. It's very comprehensive. We've written a book for this a review course, which everybody will have a copy of that book, and the lectures will follow fairly closely to that book. Now, what we try to do is we give the lectures, and when we finish the lectures, we'll have a period of time to answer questions after them. So at least during the lecture periods, we won't do any question and answers, but then we'll do some unknowns to really drive home the principles of what we've done with the course. And that will be very interactive going through the unknowns. I guess we ought to get going here. I want to introduce a person that is a close friend of mine. He actually trained me at Harvard when I was a fellow there. I met Andrew early on. The main reason I met him, we were in the weight room together working out. And then he really introduced me to orthopedic oncology and the pathology part of that. He's been a great friend ever since then. We've lectured around the world together, but more importantly, Andrew is probably one of the most famous musculoskeletal pathologists in the world. He's written textbooks on this. He's a professor at Harvard. He's now gone down to University of Miami and works closely with myself and Tom Temple at University of Miami. And we're fortunate enough to get some of his time to come over here and help do the pathology for this course. Andrew, thank you.
Thank you very much for that very nice introduction, Doug. I'm going to break the rules. We have a big group, so what I want to try to do is make it informal. And although Doug asked to hold the questions till later on, feel free to stop me as I go through this information. I'm very thankful for Dr. Agarwal and Dr. Letson and the Indian Orthopedic Association for the kind invitation, for allowing me to participate in this course. Everybody has been very warm and welcoming. Although my last name is Rosenberg, now I feel it's like Rosenberg sing. We have the wrong talk open. If you could put it in presentation format. Okay. The skeletal system is a remarkable organ system. And just like every day in our life, we generally take for granted things that are important and special. And it's not until we see or take care of a patient who has a torturous life because of an inherited disease that affects the skeleton, or we're taking care of a young individual who has a fatal disease that arises from an acquired mutation within bone, where we see the normal ravages of the process of aging on our skeleton, that we can truly appreciate the wondrous things that we can do, from a very graceful leap in ballet to something very special and meaningful like a kiss. What I would like to do in this lecture is help provide the foundational information upon which the additional lectures are going to build as we move into the different types of the pathology of the skeletal system. The skeletal system is composed of bone, and bone, as we'll see, is a wondrous creation. The skeletal system is as vital to life as any other organ system. If you were to lay me out on a stretcher, artificially ventilate me, debone me, I would die within a matter of several minutes, related to the vital function, to mineral homeostasis. As we'll see, the skeletal system houses over 99% of our body's calcium. Also, the skeletal system is extremely important, as you know, for support, movement, protection of our viscera. It is the location where our bone marrow is normally stored. And now, more recently, over the past 10 to 15 years, the very important role the endocrine function of the skeletal system plays in our body, including energy metabolism and the development of a male phenotype and fertility. Bones, there are 200. How many bones in the body? We have a fellow. I won't put him on the spot.
206.
Correct, 206 bones of the body, and each bone of the body is composed of bone tissue, and bone tissue is a biologically unique tissue because it is biphasic, composed of an organic element, the cells and proteins that they make, and the inorganic component. And you can see the inorganic component, which accounts for the greatest mass or the weight of bone, is calcium hydroxyapatite. And that's within which there is the vast majority of the body's calcium, phosphorus, important amounts of sodium, magnesium, and trace elements. What I'm going to be concentrating on are the organic elements of bone tissue, namely the cells and their proteins. But together, the organic and inorganic makes bone tissue the strongest tissue within the body. It is about strong as cast iron, but only about 1/3 of its weight because of its unique construction, having a cortex and essentially a hollow center. If we were to remove the calcium hydroxyapatite out of the bone tissue, we would have a bone that's more like a rubbery stick. In contrast, if we were to take out the proteins of bone and the cells of bone, we would just be left with the inorganic component, and it would be like a bone made out of porcelain. If I dropped it, it would shatter into thousands of pieces. It is the cells of bone that are responsible for the manufacture and upkeep of bone tissue. And within individual bones, there are a variety of different types of cells. And the ones that I'm going to be concentrating on are those that are normally found only within bone tissue, the Osteoblast lineage and the Osteoclasts. The Osteoblast lineage include the mesenchymal stem cells. These are tissue-fixed stem cells that have the capability to become stimulated, undergo cell division, and produce offspring that will develop into osteoblast precursors and then mature into osteoblasts, osteocytes, and surface lining cells. It is these cells that are responsible for making bone tissue, and you can see they only account for approximately 5% of the weight of bone. It is the osteoblasts that are making the organic matrix, the majority of which is composed of type 1 collagen. So type 1 collagen is the major structural protein of bone tissue made by osteoblasts, but for every molecule an osteoblast makes of type 1 collagen, it makes a non-collagenous protein, and we'll see they play an extremely important role in the biological function and success as bone as a tissue. The most important cell in bone tissue are the osteoblasts. And that's because of the rich array of different molecules that the osteoblast makes. It makes, as I just mentioned, the type 1 collagen molecules, but is also responsible for making collagenase. Collagenase, which is deposited in the bone tissue in an inactive form, and when osteoclasts come along, release different enzymes, they activate the collagenase to begin to break down the type 1 collagen molecules in the process of bone resorption. Human osteoclasts do not make collagenase. Importantly, osteoblasts make proteoglycans, which help anneal the collagen bundles and units of bone to one another. It makes enzymes that are extremely important in governing or regulating the process of mineralization of bone tissue. It makes proteins that on one end are anchored to some of the organic elements, and on the other end bind the crystals of calcium hydroxyapatite in a very specific manner. And almost lastly, but very importantly, it's the osteoblast as a capacity to make growth factors. Growth factors are extremely important because they have the capacity to stimulate stem cells or other precursor cells to undergo cell division and produce mature cells of different lineages. And lastly, on the surface of osteoblasts are receptors. Receptors for cytokines, as well as paracrine and endocrine molecules that are extremely important for the integration of bone tissue in a microenvironment, as well as in sync with the rest of our body systems. A metabolically active osteoblast is about the size of a macrophage, and it is synthesizing and manufacturing the matrix. Within the osteoblast are all of the major cell signaling pathway systems that have ever been described. And it's these mechanisms that allow the osteoblast to participate and play a very important role in the different endocrine functions of the skeletal system. It is the osteoblast that makes the molecule osteocalcin. Osteocalcin is the only molecule only made by osteoblasts. When it becomes modified, it binds the Leydig cells in the developing testes, which stimulates the production of testosterone, which is very vital in the development of the male phenotype in utero. It is the same molecule, osteocalcin, that also binds to the beta cells within the pancreas, which plays an important role with the production and release of insulin in our bodies, which obviously is vital for glucose and energy metabolism. Osteoblasts also are very, in a sophisticated way, related to what is happening in the adipose tissue. And in a simplistic fashion, when we eat, digest our food, and we have intake of fat that gets stored within our adipocytes, the adipocytes release hormones known as leptin, which bind in our central nervous system, which stimulates our sympathetic nervous system, which has a direct interaction of osteoblasts. Generally, the more we eat, the heavier we are, the more bone mass we have. And it's just not related to the fact that we're carrying more weight, but it's related to the tone of the sympathetic nervous system. So very complex roles and very crucial roles that osteoblasts have with regards to our endocrine system. As I mentioned, osteoblasts produce bone when they're metabolically active, and several different potential fates await for them. They can undergo apoptosis and die. They may live anywhere from several months to several decades. Another fate for them, as they are producing matrix, they can become surrounded by the newly formed bone tissue. And once they become imprisoned or enveloped by the bone tissue, that is when they are known as osteocytes. There are more osteocytes in bone tissue than any other type of bone cell. We're looking at bone tissue at high power. This is the space that the osteocyte resides, and emanating from the osteocyte cell body are numerous little tunnels through the bone tissue which house osteocytic cell processes. Here we're looking at an electron microscopic photograph showing the body of the osteocyte, the nucleus, and these represent the canaliculi, or the tunnels in bone through which the cytoplasmic processes traverse. It's been estimated that with each osteocyte, there are at least 75 cytoplasmic cell processes, and that no bone is greater than several microns from an osteocytic cell process. These are additional views of osteocytes. Here, with all the calcium hydroxyapatite removed, these linear structures, rope-like structures, represent type 1 collagen molecules, and we can see the cell body giving rise to the osteocytic cell processes. Another view of an osteocyte with the inorganic component removed, as well as the type 1 collagen, showing the tremendous complex interconnecting network of the cytoplasmic processes of the osteocytes. What are the roles of osteocytes? In the past, we really had no idea, but a lot of now new scientific evidence strongly supports that an important role for an osteocyte is that it is a sensor for our mechanical environment. It has the ability to translate mechanical force into biological activity. And when there is pressure on bone, when I'm walking, when I'm making a muscle, if I'm playing tennis or if I'm playing cricket, there's muscle contraction on bone. That results in a variety of different changes in the osteocytes that produce molecules such as cyclic AMP, which are stimulatory, which can then stimulate the osteoblasts on the surface to produce a variety of molecules in order to change the microenvironment according to the biomechanical needs. Osteocytes also play an important role in the endocrine system. They produce a molecule known as fibroblast growth factor 23, which binds to the kidney, extremely important in the control of excretion of phosphorus. It is the osteocytes that also produce a molecule here known as sclerostin, which can stop the osteoblast from making bone. And a beautiful example of the importance of that is astronauts. The reason why astronauts cannot stay in space for years is because of the osteoporosis that they develop. And it's felt that this molecule, that once there's no longer mechanical force on the bone tissue, sclerostin is produced and the osteoblasts cease or diminish bone production, osteoclastic activity continues, resulting in osteoporosis. And again, this highlights the role of functional adaptation of the skeletal system. One of the things that makes the skeletal system relatively unique in that it can respond to its biomechanical force. In equilibrium, we're in a steady state. However, when there is muscle contraction, continued muscle contraction over time, the skeletal system has the ability to increase its skeletal mass. And in the same fashion, when there is decreased muscle pull on the individual bones, there results in osteoporosis and overall decrease in bone mass. And a lot of natural experiments highlight this. I mentioned the astronauts. Here's an example of individuals who became paraplegic. This is what their bone mass was at the time of injury, and over a relatively short period of time, once there's no longer mechanical contraction on bone tissue, losing up to 50% of the bone mass. This is an example of how our skeletal system can increase in bone mass, looking at relatively young girls who are physically active in gymnastics, and during that time period, there is a significant increase in skeletal mass. When they stop that activity, relative decrease. When they start again, increase in bone mass. Maybe an important message for looking at bone health in our population to help minimize osteoporosis in later life, building our skeletal mass during the time of growth and development. And this is something that we take advantage of every day, at least certainly in some of the Western countries, are braces. How do braces cause teeth to shift in position? It is the metal and rubber bands putting pressure on the tooth. That tooth is putting pressure on the bone sensed by osteocytes, resulting in osteoclastic activity and change in the tooth position over time. And where that tooth once occupied, the space becomes filled in with bone. So we've talked about the mesenchymal stem cell, the metabolically active osteoblast, the osteocyte. The last cell in the osteoblast lineage is this surface lining cell, relatively quiescent cell. But all of the bony surfaces within the cancellous bone, within the haversian canals, underneath the periosteum, are covered by a cellular envelope of these surface lining cells, acting as a barrier for whatever is coming in of bone tissue and from whatever is coming out. And overall produces the tremendous surface area that our skeletal system has, having greater than 3 or 4 American football fields in square surface area. There are diseases that affect the osteoblast lineage. This is an example of one. This is the fatal form, non-fatal form. Here in this specimen X-ray, there's an osteoporotic skeleton, multiple fractures. Here, this young individual, if you look carefully, there are surgical scars. This young girl has already had intervention by orthopedic surgeons. More examples of the non-lethal form of osteogenesis imperfecta. Osteogenesis imperfecta, disease that produces abnormal type 1 collagen, and wherever type 1 collagen is normally found is affected. And that's why they have blue sclera. Much of the sclera is composed of type 1 collagen. It's diminished in amount, so you get greater translumination of the blood within the retina. Teeth also contain important amounts of type 1 collagen, so you get abnormal teeth production. Many different clinical types of osteogenesis imperfecta, all related to this, mutations. Mutations in the gene that codes for type 1 collagen. And as we learn more and more about the skeletal system, we see many of the diseases that we encounter are related to problems within our DNA. Any questions about the osteoblast lineage? And we'll quickly move on to the osteoclasts. We can only recognize osteoclasts when they are mature metabolically active cells. The precursor cell, which is a mononuclear cell, we cannot identify with confidence at the microscope. The osteoclast, by definition, it's a multinucleated cell. It is juxtaposed to bone and is always active, and the evidence of that is the resorption pit, or the area, the scallop where the bone has been removed by the osteoclast. Unlike the osteoblast stem cell, which is tissue fixed, the stem cell for the osteoclast is a hematopoietic precursor cell, the same cell that gives rise to tissue macrophages and circulating monocytes. And depending on the concentration of a variety of different cytokines and growth factors, that granulocyte monocyte stem cell will either produce an osteoclast or a monocyte or a tissue macrophage. I want to spend a minute on several important molecules that have been identified over the past 15 years which control the production of osteoclasts. And control is extremely important because the osteoclasts do one thing. They digest bone tissue, and they can do it like a bulldozer. And so when unleashed in an uncontrolled fashion, we can lose our bone mass in a tremendously short period of time. The molecules that are very important in control of osteoclasts are known as rank ligand, something that looks like a lollipop, and that is expressed by osteoblasts. The osteoclasts precursor cells in developing osteoclasts have on their surface a receptor known as rank that recognizes the protein expressed by the osteoclast. And when that physical binding occurs, you get the production of the osteoclasts, and also those, when there's a lot of binding, there's a lot of osteoclastic activity. They become metabolically active. The third protein or molecule known as Osteoprotegerin, the protector of bone. A variety of different cells make this molecule, and its importance is that it binds rank ligand. So the more molecules of these that are present, the smaller amounts of rank ligand are available, and that diminishes osteoclastic activity. So at any point in time, depending on the concentration of rank ligand, rank and osteoprotegerin will determine the number of osteoclasts we have and their metabolic activity. The other important thing that it points out is that osteoblasts control the formation of osteoclasts. And so when you think about all the diseases that are associated with osteoclastic activity, from something like hyperparathyroidism to osteomyelitis to the remodeling of a fracture callus, it is the osteoblast that is controlling the generation of osteoclasts. So in a disease like hyperparathyroidism, osteoclasts don't have a receptor for parathyroid hormone. Osteoblasts do. They bind the molecule, and when they do, they start producing many molecules of rank ligand, which results in increased osteoclastic activity. And that's why the pharmaceutical companies are spending literally hundreds of millions of dollars trying to develop molecules to influence this process, to cure disease or minimize important diseases such as osteoporosis. Osteoclasts, as I mentioned, are responsible for digesting bone tissue, and I'll simplify it. They do two things. They have to get rid of the organic component of bone, the calcium hydroxyapatite, and they do that by making an acidic environment. Acid on bone is like water on salt. The calcium hydroxyapatite dissolves, and this is an energy-dependent system. The osteoclast also releases lysosomes into the resorption pit that stimulates enzymes that begin to break down and liberate the molecules that the osteoblasts have previously deposited within bone tissue. There are lots of different defects or aberrations within the development and or function of a mature osteoclast, where different mutations can result in an abnormal enzyme within the osteoclast so it no longer functions. And the common endpoint of abnormalities in human osteoclasts produces a disease. And that disease can have clinical manifestations of cranial nerve palsies, bones that appear to have increased amounts of mineralization, also are abnormally formed with this Erlenmeyer-Flass deformity. And lastly, in this cross section, this coronal section to the bone, if you were to put your finger in the middle of the diaphysis, you wouldn't be feeling soft fat, but it would be hard as a rock. These are the features of osteopetrosis. And if we were to cut one of the bones right through the midsection, again, instead of having a medullary cavity filled with fat, it would be filled with this chondro-osseous tissue, cartilage upon which bone has been deposited, which is originating at the growth plate in the region of the primary spongiosa. And in osteopetrosis, the abnormally functioning osteoclasts don't remove all the cartilage and bone, so it persists and fills the medullary cavity. When we are growing and our cranial nerves are increasing in diameter, the apertures in our cranium also have to increase in diameter. That is only accomplished through the activity of osteoclasts. And so when the osteoclasts are not functioning, those apertures remain small in diameter, resulting in the production of cranial nerve compression neuropathies, which can be expressed in a variety of different clinical manifestations. Osteopetrosis was the first disease ever treated with a bone marrow transplant. And that's because the investigators understood the origin of osteoclasts, that it was a hematopoietic stem cell that gives rise to them. And here's an example of a patient with osteopetrosis treated with a bone marrow transplant. Here, medullary cavity filled with a lot of chondroosseous tissue. Here, after a period of time, one can appreciate that that tissue has now been resorbed by donor osteoclasts, and we now have a population of relatively normal appearing marrow. Other diseases that result from osteoclasts. This is an x-ray from a 65-year-old woman who was otherwise healthy, stepped off the curve or moved quickly out of the way of a tuk-tuk, experienced extreme pain, came to the emergency room with this x-ray, and we can see a poorly defined mixed lytic and blastic lesion, and the diagnosis here is metastatic carcinoma. How does metastatic carcinoma produce bone lysis? Because only osteoclasts, and again, osteoclasts are the only cells in the body that can resorb bone. Well, they produce a variety of different cytokines. Again, that can cause osteoblasts to produce rank ligand, resulting in increased osteoclastic activity, either locally where the cancer cells are, but sometimes it's systemic, and it's one of the known causes of, or the cause for hypercalcemia of malignancy. The more we understand the molecular pathways underlying activity of osteoclasts, the more opportunities there are to impact that process. This is an example of molecular targeted therapy. The drug denosumab is a monoclonal antibody that is directed against rank ligand. And so when you give that drug, the rank ligand is suppressed. That can be used treating patients with osteoporosis to stop osteoclastic activity or diminish it, but it also can be used in the treatment of primary bone tumors, is now being shown effective in patients with large giant cell tumors of bone that are in an anatomic location that can be very difficult for complete resection. So osteoblasts and osteoclasts are coupled cells, or their activity are coupled processes. They play extremely important roles in growth and development. When we start out with a skeleton this big to one about my size, which is still relatively small. During growth and development, complex interaction between blasts and clasts. You realize during the first decade of life, every year the entire skeleton is resorbed by osteoclasts, rebuilt by osteoblasts. Once you become a young adult like myself, that rate slows down, such that I turn over about 10% of my skeleton on an annual basis. I have about 1 million osteoclasts active at any one point in time. And we're beginning to understand now where and why those osteoclasts are located. It is the osteoclasts and osteoblasts in a skeleton that is no longer growing, which is responsible for the remodeling of our individual bones. The skeletal system, bone tissue, is not static. It is always changing. It is always breaking itself down and trying to rebuild it, and that's what the word remodeling represents. And again, this cellular activity, very important in mineral homeostasis, repair of this microscopic fracture, the fractures that we experience with everyday life, and again, allows our skeleton to adapt to mechanical stress. We're looking here under the electron microscope of the microfractures because it's felt that this microtrauma is responsible for bringing in osteoclasts that start the process of remodeling. The osteoclasts resorb the areas around the fracture. When these microfractures develop, they injure a cell process of an osteocyte, which sends a message to another osteocyte, which eventually sends a message to the surface lining cell for the surface lining cells to secrete rank ligand to bring in osteoclasts to begin the remodeling process of this bone. In a mature skeleton, many aspects of our life, this is what we try to achieve. Balance, But just like all processes during aging, there's loss of balance. My hair's turned gray. I don't have it all. And what happens in the skeleton as we age, we have two forms of osteoporosis. Aging, where we have a steady loss of bone tissue as the number of osteoblast precursor cells diminish, as the synthetic activity of our osteoblasts also is reduced. When I was 15, maybe my one osteoblast could make an ounce of bone. Now that I'm older, it's only making a quarter ounce of bone, and that's occurring also as I become less active physically. Also, I'm only turning over 10% of my skeleton a year. That means there may be molecules present within it, growth factors that are bound that are over 10 years old, and they denature over time. And so once an osteoclast comes and liberates these growth factors, they have diminished biological activity. In contrast, postmenopausal osteoporosis, which affects females, much more rapid bone loss, such that in significant cases they can lose up to 2% of their cortical bone mass on an annual basis, almost 10% of their trabecular bone mass, such that at least in the United States, by the time they reach their 70s and 80s, they've lost almost 1/3 of their cortical bone mass, 50% of their trabecular bone mass, and studies have shown about women that age, 50% have some type of pathologic fracture associated with postmenopausal osteoporosis. And it is directly associated with, as estrogen levels go down, actually some type of cytokine production increases, which stimulate osteoblasts to produce rank ligand, so you have increased osteoclastic activity. In an age of patients whose osteoblastic synthetic activity is decreased, resulting in this significant type of osteoporosis. And again, as estrogen levels go down, molecules such as interleukin-1, tumor necrosis factor, increases, resulting in the activation of osteoclasts. So we have increased osteoclastic activity, and that's known also as high turnover osteoporosis, such that in the end, we have a skeleton of decreased bone mass, pathologic compression fractures of the vertebral body. Normal vertebral body, osteoporotic one, which has undergone compression fractures. Scanning electron micrograph, normal interconnecting bony trabeculae, osteoporotic bony trabeculae, which have become thin and have lost their normal connections. We're looking at a vertebral body from an autopsy, illuminated from the back. We can see these round structures that look like beehives. Those represent fractured bony trabeculae with microcallus in an attempt to heal the fracture. This is what it looks like under the microscope. Loss of interconnection, thinned bony trabeculae, normal cortex with an aperture for a nutrient artery, osteoporotic cortex with massively dilated eversion systems, and one can appreciate how a cortex like this could easily break with relatively minimal trauma. So although our bone tissue is one of the strongest tissues of the body, our skeletal system is a fragile system, and we need to be very thoughtful and careful about how we treat it. So with that, that concludes my sort of introductory talk on bone. Any questions?
We'll have after your second one.
Okay. So we're going to make a significant jump in topics. We are going from relatively normal to presenting the foundation for the understanding of bone and soft tissue tumors. And that's what I want to talk about, is the basic information of bone and soft tissue tumors. I like to always provide definitions, and in the end, we can understand what are they, where do they arise, and maybe why do they occur? And through that, I will be talking about the etiology, the epidemiology, how we classify them. Very important, we're talking about neoplasms, not non-neoplastic conditions. And I define as a neoplasm, as you see here, a new growth. And that growth is either benign or malignant. And we can separate benign and malignant tumors, bone and soft tissue tumors, very simplistically. Malignant tumors differ than benign ones because they have the biological capacity to metastasize, period. But the general rule of thumb is benign tumors are much more common than their malignant counterparts. In the United States, or I would say it is my estimate with regards to bone and soft tissue tumors, at a minimum, benign tumors are at least 10,000 to 1 more frequent than malignancies. And to give you a perspective, in the United States, we have little over 300 million people, and there are little more than 12,000 newly diagnosed sarcomas on an annual basis. Other rule of thumb, benign tumors, regardless of the soft tissues or the bones, are more peripheral in location. The malignancies tend to be more central. And with regards to soft tissues, they tend to be more deep-seated rather than superficial. And the superficial soft tissue tumors, again, usually benign. Benign soft tissue and bone tumors tend to be slow-growing, usually, with some exception, plateau at a maximal size, where in contrast, the malignancies, regardless of whether they're low-grade or high-grade, will continue to enlarge and get so big sometimes it's like a tumor walking into an office with a pair of shoes. And again, importantly, I want to highlight the malignancies have, by definition, the capacity to metastasize, and the benign ones don't. Again, we always have rare exceptions. Rare examples of primary bone tumors like a giant cell tumor or chondroblastoma that has the potential to develop metastatic deposits. The malignancies, the sarcomas, are a type of cancer. And again, we break down the cancers according to the normal cell types they recapitulate. So carcinomas recapitulate epithelial cells. Like breast carcinoma recapitulates the lining cells within the breast parenchyma. Melanoma comes from melanocytes. The hematopoietic malignancies come from hematopoietic elements. And again, those tumors that differentiate along the lines of mesenchyme, we define or call sarcoma. Strictly by definition, the word sarcoma, you see, is Greek and represents a fish flesh-like in appearance. And this is what they look like, either in soft tissue or bone. The soft tissue is defined as the extraosseous tissues, exclusive of the reticuloendothelial cell system, the coverings of the brain, and reside in between the surface of the bone and the overlying skin. Bone and soft tissue tumors, and here particularly sarcomas, arise in all age groups. Important simple facts: they're relatively uncommon in the very young and in the elderly. We can appreciate that with regards to primary bone malignancies, there usually is a bimodal age distribution, particularly so with osteosarcoma, where almost 25% are occurring in the second decade of life. In contrast, the soft tissue sarcomas become higher in frequency as we get older, up into the early stages of the elderly population. And there is a relationship between the type of tumor and the age of the patient. And we really don't have a good understanding of why that occurs. For instance, here we're looking at an example of primary bone tumors. In the very young, in 2, 3, 4-year-olds, primary bone sarcoma is very uncommon. That's when metastatic disease is much more common, metastatic rhabdomyosarcoma or neuroblastoma. Young patients have NOFs. Their malignancies tend to be Ewing sarcoma and osteosarcoma, whereas in adults they more frequently get enchondromas, chondrosarcomas, and different types of fibrosarcomas. The same holds true with regards to soft tissue tumors. Different types are associated with different age groups, such that in children, one of the most common sarcomas are rhabdomyosarcomas. In the adult, different types of liposarcoma become more numerous. And again, this diagram just highlights what I said before. With regards to malignancies, they're very uncommon in the peripheral portions of our skeletal system and soft tissues, and the more central you are, the more greater the likelihood the tumor is going to be malignant. Approximately 1/3 of all soft tissue sarcomas occur in the deep soft tissues of the thigh. Again, why that is, we don't know. And approximately 50% of all primary malignancies develop around the knee joint, areas associated with some of the most active growth plates in the body, that of the distal femur and proximal tibia. The sarcomas, again, present as a progressively enlarging mass that can produce eventually pain. We can appreciate the prominent veins overlying the skin of this large soft tissue sarcoma. Here again, a high-grade osteosarcoma resulting in resorption of some of the cortex growing into the soft tissues. The classification of soft tissue, of both bone and soft tissue sarcomas has gone under a tremendous amount of change from the 1800s, when they were classified according to their macroscopic appearance, of whether some looked like pancreatic tissue, whether they were cystic. It wasn't until after the use of the microscope, the classification of different cell types, that they became classified according to their histologic features. The normal tissue type that they most closely resembled. And that was the basis of the histologic classification of sarcomas, and it was also felt to be very important in the pathogenesis or the development of these sarcomas. An osteoblast became an osteosarcoma. A fat cell became a lipoma or a liposarcoma. That type of hypothesis or theory no longer holds true. And what our current understanding is, whether it's a benign or malignant tumor, all the neoplasms are a genetic disease, resulting from a mutation in likely either a mesenchymal stem cell or a precursor cell. And depending on that mutation and the control of genetic expression determines the phenotype of those cells. So if I am a stem cell, I undergo a certain mutation that causes me to store a lot of lipid. It's similar morphologically to a fat cell, and I'm a lipoma, or if I can metastasize, I am a liposarcoma. And on that basis, we subclassify all of the tumors according to their normal tissue counterparts. About 90% of all sarcomas have a normal tissue counterpart. But there are some that we don't know what their normal tissue counterpart is. Uncommon tumors, such as an epithelioid sarcoma, but they have consistent clinical manifestations, consistent histological, pathological, and molecular abnormalities to make them a defined entity. And overall, bone and soft tissue sarcomas, we have over 70 different subtypes. And that's what makes the pathology of bone and soft tissue tumors complex, because of the broad array and combination with the rarity. Why do we develop sarcomas? In the past, trauma was thought to be important. A child riding a bicycle falls off, is injured in the distal portion or around the knee. There's swelling and redness, and never goes away. 2 months later, an x-ray is taken, and there's an osteosarcoma. Evidence into looking at doubling times of tumors have shown that most sarcomas have likely been present for a minimum of several years, from when they start from one cell to billions of cells. It takes a considerable amount of time. So trauma likely has nothing to do with the generation of tumors, except with rare examples. Rare examples of some athletes, like American ice hockey players, constantly being checked into the boards, constantly being hit, developing fibromatosis. Same thing with fibromatosis developing in surgical scars, likely related to the trauma, the induction of healing, and an abnormality of that process. There are a variety of different diseases, from bone infarcts, Paget's disease, to well-defined molecular inherited diseases associated with different types of sarcomas. Even though we know what the molecular underpinning of these diseases are when we look at the significance of their presence in the sporadic sarcomas, likely playing a role but not the prime role. There have been a variety of different relationships between certain types of exposures to toxins, like thorotrast and development of angiosarcoma in the liver, asbestos mesothelioma, Agent Orange for the American Vietnam vets, and the development of soft tissue sarcomas. Uncommon relationships account for a very small percentage of the sarcomas. So the vast majority, we have no unknown cause, but again, going back to this, it is mutation in the DNA that is resulting in the development of sarcomas. The thing that we don't understand is what is initiating the very first arrangements that are occurring in our chromosomes. And I'll provide you just a little background on molecular biology of sarcomas, since we are physicians and we're always in the process of learning. When you look at the family of sarcomas, either bone and soft tissue sarcomas, you can break down their molecular abnormalities into two major groups. Those that have very complex abnormalities, like the American Society, to those that have very simple abnormalities. And these simplistic abnormalities are reflected in a translocation, reciprocal translocation, where a segment of DNA from one chromosome, a segment of DNA from another chromosome, switch places, producing an abnormality. And some of these translocations, and many of them, are relatively specific for certain kinds of tumors. The complex translocations, you can see, account for the majority, about 2/3 of all of the high-grade sarcomas, whereas these reciprocal translocations account for about 1/3 of all sarcomas, and the number is growing with regards to the number of translocations that we are identifying. Regardless of the number or the type of translocation, the result is that you get a fusion of two genes adjacent to one another that normally weren't neighbors. That produces an abnormal protein, a nuclear transcription factor, and that nuclear transcription factor controls genetic expression and helps drive the development of the neoplasm, both biologically, in the sense is that it's aggressive and can metastasize, and also with regards to its pathological manifestations of, is it an osteosarcoma or a chondrosarcoma, i.e. its line of differentiation. So the production of these fusion genes and their proteins, again, drive the biological processes of these sarcomas. And the identification of these processes is extremely important because it opens the window of introducing some new types of therapy. And these are some of the names of the sarcomas associated with complex versus the simplistic translocations. The high-grade osteosarcomas, the chondrosarcomas. In contrast, tumors such as Ewing sarcoma, synovial sarcoma, and it's a much longer list, have these specific translocations. In the pathology laboratory, we can take advantage of it. We can take advantage of identifying that translocation using the process of fluorescent in situ hybridization, where we have a visual probe on one side of the chromosome adjacent to the breakpoint, another color on the opposite side of the breakpoint. So if my arm is chromosome 22, and in Ewing sarcoma, this is the point that the chromosome breaks. I have red here, green here, and when I look at it under the microscope, this is normal, red next to green, but when the chromosome splits apart, we can see we have a separated red and green signal. When I see that under the immunofluorescent microscope and I know it's a malignant round cell tumor, I can tell Dr. Letzen with 100% confidence, you're dealing with a patient with a Ewing sarcoma. And again, this type of technique we're using on a daily basis on a variety of different sarcomas that have the specific translocation. And this is an example of the utility. I'm older now. When I was a resident, it was in the 1980s, before some of the current understanding we have of the molecular abnormalities, before immunohistochemistry, and we would be confronted with tumors like this that we would characterize as a malignant small round cell tumor. Which one here is the Ewing sarcoma? If you look carefully, there are subtle differences. Little extracellular pink material here, there are some more prominent blood vessels. But which one is the Ewing sarcoma? Doing FISH, we can see that this tumor has the 1122 translocation characteristic of it. This is the Ewing sarcoma. This is a lymphoblastic lymphoma that presented in bone. This turned out to be a mesenchymal chondrosarcoma. This was a small cell osteosarcoma. So where are we going now? We're really, and very importantly, trying to understand the molecular biology active in any specific tumor. And the importance of that is once we can identify the proteins and the pathways that are active in that tumor, and it can be on an individual basis, we may be able to develop new forms of targeted therapy. I would look at it like this. We're seeing an orchestra here, and we have the conductor. The molecular mutation that produces the protein is the conductor telling all the different genes what to do. And here it is on a diagram. This mutation now activating a variety of different pathways that makes that cell able to live longer, replicate faster, digest its matrix, get into blood vessels, and live once it spreads to the brain or the lungs. It also gives us an opportunity to create an inhibitor to target that molecular abnormality and maybe cure the patient. Relatively short list of the different types of agents, the molecular targeted therapy that are now being used to treat different types of sarcomas. I want to quickly end very brief discussion of some important concepts because you're surgeons, I'm pathologist, you get information benign versus malignant. We separate these two important biological processes by looking at the degree of cellularity of the tumor, how much the tumor cells vary in size and shape, their mitotic activity, necrosis. Benign tumor, not very cellular, a lot of extracellular space, here filled with collagen between one cell and the next, uniform in appearance, an example of fibromatosis. In contrast, a densely cellular tumor, cells that are round, others that are spindle-shaped, some that are small, some that are gigantic, very dark nuclei. Distinguishing benign and malignant, very important, but also within the realm of malignancy, extremely important to determine is this tumor associated with a low risk or high risk of metastatic disease, because that will determine whether that patient gets systemic therapy or not. And here, just examples of relatively indolent benign lesions, such as a vertebral body hemangioma or an osteochondroma, a sarcoma, low risk for spread, such as dermatofibrosarcoma protuberans, and then those tumors that are high risk of spread, such as a high-grade osteosarcoma and Ewing sarcoma. We have come a long way, even from the past just 20, 25 years with regards to our understanding of benign and malignant bone and soft tissue tumors. Has taken a combination of a tremendous amount of effort, really blood, sweat, and tears, as well as creativity, working together. Again, I think we have a bright future to build the infrastructure of being able to one day cure the vast majority of bone and soft tissue sarcoma. So very simplistic points to remember. Really, neoplasms of bone and soft tissue, they're genetic diseases. We classify them according to their normal tissue counterpart, and
their biological behavior. So with that, I'll stop. I know I'm a couple minutes over. I'm happy to entertain any questions. Thank you.